This is session number 31 of the Performance Place Sports Care Podcast. I'm so ready.
Welcome to the Performance Place Sports Care Podcast, where you can learn about sports injury theory, rehab, diagnosis, and how to understand the doctor lingo you didn't understand at your appointment. And now, your host, Dr. Sebastian Gonzalez.
Hey, it's Dr. Sebastian Gonzalez again with Performance Place Sports Care Podcast, and we have a guest today. It is Cody DeMack. He's probably going to correct me, from Maximum Performance Chiropractic in Costa Mesa. And the reason why I brought Cody on is actually because I think he has a lot of good tips and tricks and good, easy ways to break down care and rehab and movements to people. And we've met on a lot of occasions, and we're good friends now, and we meet and break down cases together and whatnot. And it seems like, so he's got a really, really good way of putting things together, and I think he treats people very, very well. So I trust his judgment on a lot of stuff. I am going to just ask him some questions and just let him kind of run with it. So, Cody, say hey.
How's it going, everybody?
Hey.
Hey.
Okay, so Cody, why don't you tell us a little bit about yourself? And I know you practice a little bit different than a lot of traditional chiropractors. Can you tell us how you got to be like that, and like who influenced you along the way, and so on?
Yeah, so name's Dr. Cody DeMack. Dr. Gonzalez said, my practice is in Costa Mesa, California, Maximum Performance Chiropractic. My practice is very different than typical chiropractic practices in terms of we only do one-on-one time. Typical visits about 30 minutes, and we integrate not just like one technique or anything like that, but we kind of structure our visits towards the patient. So we create patient-centered care, whether that's if they need some, they do need some mobility, so we do some typical chiropractic adjustments or soft tissue treatments, but mostly we do a lot of active rehabilitation. And kind of finding what the patient needs.
So he's looking at me right now, and he's like, I know you're going to ask me what active rehabilitation is. And,
yeah.
But before I ask it, though, I know that people are probably wondering like, well, why am I listening to this podcast and hearing, what am I getting out of this? And I think that, so we're going to break down and go into the reason why movements are important, different types of treatments out there, which ones are the best for what type of case, and so on. Yep. And I know we'll go into that, but tell me what active care is.
So active rehabilitation is... my best way of putting it, think like some potentially strength and conditioning, some corrective exercise, and some traditional corrective exercise stuff, along with some spice from other strength coaches and that type of stuff, and balled up into this little goodness of creating movement in people.
That was the most confusing thing I think you could have told me.
Yeah.
But I know that
get people moving around.
Okay, yeah. And your motto is basically movement is medicine. I read that. Is that trademark, by the way?
It better be by the time this goes out, then.
Yeah, I'd strongly suggest that. I don't know if I told you, but I told you about my trademark initiative before.
Yeah.
Yeah, we should really do that. But so you mainly, your style mainly roots in, like, how did you learn to treat people the way that you do, or how do you decide what type of care someone needs?
Well, I guess a little backstory is kind of warranted here. I've always been interested in rehab and therapy, moving around and stuff, just from previous injuries in high school, stuff like that, going to physical therapy, and actually got talked into going visit a chiropractic school, and I saw that I can do some actual rehab with patients, not just passive care. But going through chiropractic school, I ended up having my third back surgery, and it kind of led me to seek out information how, one, to prevent it from having a fourth lumbar surgery. Also, how to prevent it in my patients.
What kind do you have, anyways?
First two surgeries were microdiscectomies, and then the last surgery was an anterior approach lumbar fusion, L4, L5, S1.
So because I know that most people might wonder, I don't know what these big words are. So a microdiscectomy, it's pretty common.
Yeah, they go in and they shave part of the disc that is protruding out or herniating out, potentially touching a nerve root.
So I know that a lot of patients will come in and think this is an end-all cure to their back pain.
Yeah.
So what is your response to that?
It's not. It happened for a reason, mm-hmm. and that's part of the way we approach care is trying to find the movement issues, whether it's mobility or control mobility, that potentially caused that, because there's always a root to the problem. It's never just the site of pain. So something made that hurt. So whether that's the way somebody moves, or whether that's poor training or poor advice in certain cases, that needs to be addressed, no matter if you're going to have a surgery or not.
So can you give me an example of, I know that I'm much better at explaining reasons for taking a certain approach with care when we actually break down and go into a certain case. Is there a certain case that you can think of right now off the top of your head? Obviously leaving names out of the whole podcast, but like just go into like how you feel the progression of their movements led to a need for a discectomy.
If I feel like they should have had it, or...
Well, no, what's the progression of like getting to that point?
Oh, getting to the point?
Because I know that we got the straw that broke the camel's back type of thing.
Right.
But what is the lead up process? Because I don't think a lot of people understand that.
Yeah. Well, again, every person's different, because people have different types of spine. So I'm going to say the word morphology, and you're not going to really know what I mean. But like people have different disc shapes depending on your genetics. But certain people are more susceptible to disc herniations because of certain disc shapes. So Dr. Stuart McGill has done a lot of research on this, and he's shown that repetitive flexion, bending forward, if you will, or bending forward and then rotating to a side, will actually, in time, create a bulge, and then further along, potentially create a disc herniation to one side or the other. So I would say kind of bending forward, sitting in full spine flexion, if you will, for long periods of time, and then going load that too, or loading, with weight, picking up heavy weight with poor form. I mean, it really depends, and we don't want to scare people from moving, so we don't necessarily want to banish spine flexion totally. Mm-hmm. But it does need to be monitored in some cases.
Well, I was talking to a guy the other day that I was lifting with, and I was actually kind of mentioning that same thing about. So we only have a certain amount of flexion moments is the thing, right?
Right.
So you can only bend forward so many times before you blow something out, and so on. And I told him, he's like, no. He's like, I'm like, yeah, really. I'm like, I believe it. Yeah. But so his argument was like, like we're going to make that incorrect movement many times. Why not just learn how to do it really well?
Yeah.
So I actually haven't even thought of it yet, like, nor do I want someone to try that in my office and possibly blow something out in my office. But Is there instances where you would condone doing something like that, like repetitive flexion, sit-ups, curl-ups?
I think it's within context. I mean, that you can do a curl-up or you can do a crunch, and I believe not have it just depends on how much motion you actually put in the spine. So I think the trick is to do more of a sternal crunch, so kind of where the rib cage comes down the front, and have that move down. So you are getting some anterior abs, but you're not putting the load, if you will, on the lumbar spine. To answer your question, again, I'm probably not going to do it in my office. I'm not going to load it, because typically what I see in my practice are people who where flexion or bending forward does irritate them. It makes them worse, and it makes their pain worse. And so we have to find that, mm-hmm. and then kind of set a system based off of that.
Yeah, a lot of times I see that they, not to say I don't want to teach control with excessive motion forward or curling forward and extending backwards, but I kind of feel like they're doing that enough throughout the day. I don't know if I want to add any more to it.
Yeah. Again, it depends on their daily activities, and
mm-hmm.
and their postures. Even if they're a desk jockey,
mm-hmm.
what are their postures when they are sitting down?
So I saw actually that you guys did a video. By the way, Dr. Cody, I know they don't like to be called Dr. Cody. I'm going to call you Dr. Cody anyways.
Don't ever do that
again. So he, actually they have some YouTube videos out. And I know one of them I saw was how to sit.
Yeah.
Can you explain how to sit?
Yeah, that's actually pretty easy. Most of the chairs that we have in today's society kind of tilt back, or if you will, and they're made to lean back and just kind of relax. If you're going to be sitting for a long time, it's probably best if you sit towards the edge of a chair and not sit up through the spine, so not extend through your spine, so to speak, or straighten up through the spine, but more so roll through the hips. So if you will, if you're kind of observing yourself and you're sitting with a round low back, You could put your hands on your pelvis, and you could kind of tilt your pelvis forward just a little bit. And what that should do, if you do it correctly, it should kind of upright everything. So it's almost like a sprocket effect, if you will. You turn one sprocket and everything else follows up the chain. It actually puts you in pretty good neck position also.
So you're saying don't pull with like make a proud chest or anything like that?
Yeah. That's only going to cause some irritation because you're starting to use prime movers as postural stabilizers, and that'll create some irritation.
Ooh, you're getting into some deep stuff now.
Yeah,
Okay.
yeah.
So I might as well just go on that route a little bit. So if anyone's heard, I don't know if this podcast is going to come out before the one I did on shoulders, the 3 P's of the shoulders. Actually, I think that one's out already. But we talk about rotator cuff muscles as humeral protectors, as well as there's scapular stabilizers, and there's movers, which would be the lat, the pec, and so on.
Yeah.
Can you explain in the spine, in regards to posture, which muscles would be the ones that you really want to address in regards to issues of back pain and posture and so on? Or you can take this a whole different way.
I would actually, I would rather not, because I think if we start to label muscles in the spine, then that's going to kind of direct people to thinking of low back pain as like a single driver, as like one muscle. Is really very reductionist in terms of, if we look at the global thing, movement. I think we should look at it more so of like, how do people move through the hips? Do they have proper movement whenever they are executing lifts? Do they have adequate spine mobility, and whether that's in the mid-back, and we call it the thoracic spine, or is that, or in the low back? Even some people do need some mobility in the low back. So I would veer away from identifying muscles, because everything kind of depends on other areas. Our little friend called regional interdependence. So
wait, one more time. Bring it.
Regional interdependence.
Okay, we got to go on this. So I don't know. By the way, I don't know if everyone knows. So actually, Cody's one of my bounce ideas off of guy. Once every couple of weeks, we get beer and pizza and just talk some stuff through. So I usually come away with something good, and this is probably the one thing I'm going to get this time. So regional interdependence.
Yeah.
Bring it.
All right. So so basically, regional interdependence, I believe, if I have my sources correct, originally came from Vladimir Janda in Czech Republic, and it talked about the layered syndrome. The same guy who came up with lower cross syndrome or upper cross syndrome. Some people may have heard of that. Basically, what that means is certain areas depend on other areas. So your low back depends on how your hips move or how your mid-back moves. Your shoulder depends on how your mid-back moves, or how well your neck moves. So basically everything's connected through this chain.
Oh, got it. I haven't heard that term before, but I've heard the
explanation. Yeah.
Yes. Usually it's
the joint. It also knows the joint by joint approach. So
yes, the more the long-winded one. Yeah. The one that was supposedly written on a dining room napkin.
A napkin. It wasn't it was a bar napkin.
A dive bar napkin. I'm sure there was peanut shells and vomit all over the floor.
I hope not.
Okay, so now we talked about like the importance of movement and so on. Is there a way to actually assess this at all?
Assess movement?
Yeah.
Totally. And there's no one way. I mean, you can assess movement right now by going to an airport, or I don't know who goes to malls anymore, but going to a mall, just watching people move. How they get out of the car, how do they pull the door open, how do they reach in their pocket for their money, what do they look like when they drop the quarter on the ground and they pick it up. That's assessing movement. But if we're looking at a clinical approach, again, there's no one way. As long as you are assessing movement, you're not just looking at things statically, like traditionally in our profession, taking X-rays and solely treating off of the X-ray, which I don't think is an optimal approach, because that's not how we sit, and that's not how our bodies are throughout the day. So there's many roads to Rome, so to speak. It's the old saying, but. Yeah, you have to. In my opinion, you have to have a way of assessing movement, no matter what your method is. So,
mm-hmm. So with, I always say that, at least with like how much you're talking about, like going to the mall, or like looking at people like because your assessment starts right when they walk in the door.
Immediately, yeah.
And that I always consider as like, what are your habits or what do you normally do? But we have a guy that comes in here that like I swear every time he comes in, we have to reteach him how to do everything. And it's like he forgets. But when he like dials it in, his movements are not bad. In regards to when you teach something and you are teaching that movement, is there ways to figure out how to learn if they're doing it well?
Yeah, I think you just figured out. You just said how to figure out if they're doing it well or not. Is what's the what do they come back with, right? What's the retention of that movement? And how if you're teaching somebody to move, there's certain ways you can the science has shown that there's specific ways that you should coach, especially if you're coaching or teaching a movement. There's certain things you should do. Whether that's first thing you would do is try and change their environment, and see if you can get the reaction that you want to get out of them, no matter what movement it is. I think it's the dynamic systems theory. Guido van Ryssen. If you haven't looked at any of his stuff, definitely you should look into that. Basically, you want to change the environment to try and get say you're trying to teach somebody to squat or hinge. You don't say a word, you just change their environment. So if you're trying to get somebody to squat, changing the gravity, you can use like a TRX, right? So kind of you're able to sink back a little bit more. Now, if you're going to use verbal coaching, try not to use body parts, because the brain doesn't see body parts. It sees, it sees movements and pictures. So using analogies, metaphors, that type of stuff. You've had coaches that have tried to explain something to you and you didn't get it. And then they were like, look, it's just like this. And then you're like, oh, because they use some type of metaphor and analogy and it just clicks, right? Those are the things that's shown time and time again in science to actually help with retention. So I think your number one, the number one thing I talk to trainers about when I do some workshops with personal trainers or strength coaches is like, are you having to say, cue them again, like, oh, don't forget shoulders back, because they're not retaining that, right? And they keep having to say it. So you have to change something if you're, you can only, I like to tell them you should only say shoulders back so many times. If it doesn't work anymore, change the cue,
Well, I wonder if I've always thought that I know there was cues that they gave me through sports in high school. And I don't know if I understood the importance of actually doing it versus, I did it because I want to hit a baseball.
Right.
I just wanted to make so I just remembered and I cycled through, squish the bug and backhand the ball. So, but when it comes to like exercise or rehab, I don't know if do they understand the importance? Like they must, if it matters to them that much, why don't they retain it? At least with sitting, how many cues do you use? Like 3?
Right.
Surely this can't be that hard.
Well, I think in order for the connection for them to make it, if they're going to retain it, you have to audit. So you have to see what hurts, then make the intervention, and then retest. Right, it's called a clinical audit process. So, if somebody has pain with in their knee with a squat, you do an intervention, even if they're not quite getting it, so to speak, but then they kind of start to get it, and then you retest, and the pain's less. Right then and there, that should create buy-in. Now, again, how you taught the tests and what words you use and whatnot, those are important too, whether or not you're going to get the actual retention.
So when you're teaching people, I know that every time you go and teach people how to improve their movement or how you teach them some type of cues when they're going through your office to make it so their pain dissipates. Yeah. Is there a certain amount that you stick to, or that do you show them one thing, 2 things, you wait till their brain is about to explode? Is there, how do you gauge this?
There's definitely a limit because people only have so much attentional capacity, and people are people, and they get busy or they get distracted. So if we send them home, if they get sent home with a sheet of 15 things to do, chances are they're not going to do that. We try and max out at 3 to 4 things. If the person's really competent, we'll give them 4. So, and that's not adding on every visit. That's changing if we do change. But we try to be as specific as possible the first go around, so we don't have to change too much in the beginning. Because we would like that to be the the prescription that we give them, we want that to be the one that works, period.
Mm-hmm. You ever go through cases where you're like, that first go around didn't work, I need to retract and start again?
Oh, totally. Yeah. It happens. Unfortunately, it does happen. You know, we're human too. You know what I mean? We're not perfect. So we would like to think that, you know, we're pretty decent at. We'd like to think we're pretty good at assessing and trying to be as specific as possible. But we always miss something. Everybody always miss something. You know, even the top specialists in the world, they always miss something. You know, that's why they call it practice, right?
Yeah. No one ever wants to be the one that's practicing.
Right, yeah. They not ideal, but
they always want to hear like, yeah, I've seen this 5 billion times.
Yeah.
Well, you know, on that same note too, like I don't think we ever talked about this, but like the amount of times that I know I have people come in here that get frustrated about they've been seen 30 times, 40 times at some other place, and you know, then also they go to some guy who says, if I don't fix this in one time, then I don't want you to come back, type of thing. Like how many times is good enough to know that they're gonna have a good response? Because we do have to backtrack a couple times, you know.
Yeah, I think if you have enough time in the first visit to do some type of intervention, which is ideal, you do at least a little bit of intervention the first time, and there's improvement there, then I think the statistics say there's a 50% chance of having intercession improvement or
intercession,
like between sessions.
Oh, got it.
So like before the next session, there's going to be improvement. I think it's actually higher than 50%. I mean,
like intermission.
It's pretty high actually. I mean, we know within like the first 3 visits for sure if we're gonna make a really solid impact, especially in certain cases too. You know, because we're pretty, you know, your approach is always gonna be different for everybody, but there's certain like specific things that we know that something works really well for. And if there's a pretty good change, if there's a change in discomfort and objective findings, so things that I find also, then we know that person, if they do their homework, obviously, should fare fairly well.
But now with, you said, so intercession improvements, so it's pretty common to have improvements, but then a little relapse.
Yeah, depending on what it is, yeah. You know, we call it picking the scab. So everybody's going to end up picking the scab. So they're going to go through they're going to do something that, not everybody, but they potentially could do something that will irritate the painful area. You know, whether it's shoulder, low back, knee, you know, there's a chance they're going to do something. And it's totally fine, totally normal. That's what people, you know, just tell them, don't freak out. You're okay. You're not going to die, you know, just stick with it. And sure enough, I mean, about 99% they come around.
Yeah. I don't know if I told you, up in the other room, I have, in my office, I have the rules of rehab. One of them is, you're bound for a flare-up. Just handle it like deal.
Okay.
I'd say deal with it, because it's gonna happen. It happens to everybody, you know. Hopefully, if they know it and expect it in the beginning, they're not gonna freak out and think it's just the wrong thing and so on. And
yeah, I try and not let tell people that they might have a relapse because I don't want to be like they're living in fear, But it's funny, like 2 years ago. I had somebody come in with a pretty typical low back disc and responded really well. We call it video game position. So just kind of laying on your stomach, up on your elbows, like you're playing video games, back in the day. And for some reason I said, you know what, you're going to be fine. Probably in about a week, it might flare up again. Just do this, do this exercise here, what we're doing, and you're going to be okay. It'll calm down in less than a day. And sure enough, a week later, she had a flare-up, and it calmed down. I was like, did I just, nocebo this person? Did I just make her happy?
The brain is powerful.
It is powerful. Yeah, totally. Jedi mind trick. You will be fine.
Hey, actually, there was actually a guy, I don't know if I told you, he was... He had an Achilles tendon issue.
Yeah.
And he was a young dude. He had a good job and everything. I think he was very confident in his ability to make money. So I asked him one time because he told about all the things he couldn't do, and I'm like, how much money would you pay me right now if I could just touch your calf, just one finger, just touch it, and it gets better. But it's a guaranteed 10-year guarantee that it's going to be better for 10 years. How much would you pay me? He's like, I'd pay you everything in my bank right now.
Wow.
Yeah. I'm like, okay.
Did you touch his calf?
Yeah, I did. I said, if this works, I want you to come back.
You made the money transfer first, right?
Well, no, I think the touch was the money transfer.
Oh, yeah. He was bankrupt.
Hey, he can make more, he said. Okay, so back on to actually, what kind of conditions do you think work well when you improve movement?
I mean, I think any and all musculoskeletal issues, so issues dealing with muscles, bones, and joints, aside from broken bones. But I believe almost everything can. Now, there's certain neurological conditions where we need to refer out, but even some of those too, some neurological conditions, movement can help help the situation too. So
well, so with I know that I find it easier to explain to patients that lower extremity or foot, knee, ankle, hip, low back are a little bit easier to talk about movement. But when you talk about, let's just say you had a contracture in a finger,
yeah,
like how down like that route when you get into wrists, fingers, elbows,
yeah,
non-projectile throwing people,
right.
How do these come about? Like I know that you got the repetitive stress injuries and so on. They go to work-related conditions. How would someone like that improve with movement?
The caveat to improve with movement, there's always going to be something that's probably inhibiting movement anywhere, whether it's mobility issue. So, when you start talking about specific things like in the hand, there's still probably something, we call it up the chain, so further up the arm or into the mid-back or something like that, that's kind of allowing things, basically the weakest link's going to break down. So I think that needs to be taken care of before we even, before we can start talking about movement. I mean, there's some cases too where, we create some decent stability in certain areas, and then movement frees up too. So it works both ways. But it's tough. Those are tough to call. I think case by case, obviously, is going to be how you approach it.
Now, I know you've gone through a lot of educational seminars and whatnot over the years. In one of the prior podcasts, actually, there was a guy who learned a bunch from different books that he read. Is there certain books or like self-educational tools that you recommend to people? I know you read a bunch.
I actually do better listening. When I read, I tend to get a little distracted. Better listening and talking and kind of going through stuff. So if I'm not taking seminars, I'll listen a lot to some podcasts. I'll listen to some lectures on YouTube or things like that. So I do plenty. I don't know if you want specifics or anything.
Well, I mean, I think I creep you on Facebook and Instagram all the time, so I know where you're at.
I'm tracking you.
Yeah, actually, that credit card you use, you think that's just one of those newfangled chips, eh?
Shoot.
But no, it's like, is there anything good, a reference that you think, like something easy a patient can, besides this podcast, obviously, that they could learn from? Because I think the big issue with patient compliance, I mean, I'm not blaming it on the patients, but they don't understand. They've been fed all this other stuff that, gosh, I almost named off a bunch right now that I don't. I try to say middle ground on these things, but
right. I mean, you're right. I mean, Dr. Google will get you in trouble.
Yeah.
Well, Google and WebMD aren't actually if there's musculoskeletal pain. Pretty much everybody comes into me with a self-diagnosis from WebMD says they have 6 weeks to live too. So, it's kind of tough. And it's hard to direct people to certain avenues in terms of treatment. I think Craig Liebenson has a pretty good Instagram to follow. His is usually very empowering and very movement. It's definitely movement related and active rehabilitation related. So getting people to move around and be empowered and take control of their care. I think trying not to dive into fads or dogma, so to speak. If people ask you to be, you want to be a rep, then You want to sell their product and run.
You want to be a rep?
Yeah. Know how you can make passive income.
Yeah, that is the thing.
That's a thing. Yeah.
Yeah, I think I got approached that a couple times early on in practice.
Yeah.
They're scary.
Yeah.
They're real scary, especially when you got loans to pay and everything.
Oh my God. Yeah.
So I know that I always struggle with when people come in, since we're both chiropractors. We get pigeonholed with the back, spinal, all that kind of stuff, and then I always joke with everybody that they ask if we do physical therapy, and I say no.
Oh, yeah.
But I'm like, if here's the thing: if I give you a squat, it's called physiotherapy. If a physical therapist gives you a squat, it's called physical therapy.
Yeah.
And if a trainer gives you a squat, it's called a squat. So, is there certain things, questions that you think that people that are listening to this podcast that aren't anywhere close to us can ask the person who's going to apply their care, no matter what their credential or whatever? Is there a few things that you think would be helpful to them in screening someone who's going to do a good job with them?
Yeah. I think even they can, without even asking questions, they can kind of get an idea of what to expect. I mean, in my opinion, the practitioner, whether it's physical therapist, chiropractor, should ask a couple questions, which we ask at the end of every new patient history. What are your fears and worries? So they need to know what you're afraid of and what you're worried about when you're, in terms of like, the ending of this. So also we ask, what are your goals? Because if the practitioner doesn't know the goals of the patient, then there's no end in sight, you know? And we also ask, what type of treatment do you expect to receive from us in here? So that gets it all on the table right then and there. I'm a chiropractor, but what are you expecting out of me? Are you expecting just to get adjusted? Or are you expecting like just rehabilitation? Are you expecting just soft tissue? So there's an open line of communication right then and there. And also, we ask, what is your, in your mind, what are your expectations in terms of timeline to have, their issue resolved? We want to know realistically where they're at, and in their head. So we know. I think questions that they can ask, or also if they don't even have to ask, if the chiropractor tries to sell them a large package, I would say run. Okay. If the chiropractor or physical therapist doesn't put them through like a full body screen, even if it is just the wrist, even if it is just the elbow, I think a full body movement assessment is warranted. Those are little things where they don't even have to go out of the way and feel uncomfortable in asking. I think one thing is one question they can ask is like, what is your goal for your patients? I mean, that would be a good one. What do they want? Like, I love it when patients ask me, what do I want for my patients? I'll tell them straight up, and I'll be honest with them too. I'll tell them, hey, we want to get you better as fast as possible. In a way that things stick. And it's not just a quick fix.
Well, I know there's definitely a lot of people that come in for quick fixes. I always I get a little alarmed sometimes when I see that someone comes in definitely knowing what they want done.
Oh yeah.
It is a very
never do what they ask either. Ever.
Yeah. Well, we've talked before about, I don't know if I told you I did a podcast on, I think I called it Death of the Technique. So we had that conversation one time where all these different techniques and methods out there, and then you go there and you end up getting that technique or method. But it's really just a tool chest.
Yeah.
So you got to do what's right for them.
Yeah, it's hard when, it's almost better having a patient come in who's never been to a chiropractor before. So the expectation's not specifically, it's not set, because there's so many techniques in chiropractic.
There's even more now.
I know. When I was in school, I think there was like over 250 or 300 or something like that. And obviously there's more. We're only going to have more, It's almost better not to have anybody, it's almost better to have somebody who's not been to a chiropractor before, And so it's hard out there for a chiro, man.
It kind of is. Yeah. I always try to actually not tell anyone I am.
Yeah. So I started using the term, movement specialist.
The movement by the way, is there a credential that you have to be a movement specialist?
Say it again.
Is there a credential you have to be a movement specialist?
No, I don't think so.
It's still we can coin that right now.
We could coin it, probably, yeah.
Okay, so there's a date on this podcast, the record date. It's kind of like when you send yourself a mailed envelope with an idea in it, but never open it.
Yeah.
Yeah, I think that
I
works.
have notes on my phone, my iPhone, in the notes portion that I haven't like opened since like 2 or 3 years ago because I don't want the date to go out of date.
Just don't edit it.
Just never edit it. No.
Well, I think you could screenshot it.
Yeah, that's touche.
Oh,
I think I did
Well,
actually.
you can email it to yourself unless the ideas
Screenshot
really
it,
out.
email it, save it. Don't put it in your Yahoo account. Get hacked.
No, I thought the cloud was getting hacked.
Oh, was it?
Wait, was Yahoo got hacked?
No, Yahoo got hacked big time.
Really?
Yeah.
Well, you strike me as someone who has a Hotmail account, anyways.
Yeah, it's got like my former age in it or something like that.
Yeah.
Something 16.
Yeah, and it is attached to your MySpace page.
Yeah. Still open. Still check it. It's only bands that are my friends now.
Oh, on MySpace?
Yeah.
Is that still available?
I think so. Yeah. I think I closed mine down.
Have you tried to log in?
I haven't been on there on MySpace in probably 2 or 3 years.
I think.
Because I think I checked. I checked to see if it was open and I couldn't find it, so I guess it's closed.
You know, the problem is that you tried to log in, which means that the next time someone looks, it says last login. It was like it's like last week.
Yeah. I haven't been on it in like 6 years, 7 years.
Yeah, except for that one date where you checked
it.
it.
I was like, hey, let me check this. And I tried logging in. Yeah.
I wonder if that old girlfriend contacted me on there.
No.
Okay, so last couple questions is that you're really good with cues and whatnot, and like getting people to be able to do motions easy. So I know that we talked about sitting, and I know that you are more of a tactile, hands-on cue thing, anyways. But is there a couple things or life hacks you can give people right now, like how to sit well, or I'm sure they're probably driving or in an airplane, or I mean they're probably sitting there right now.
Yeah.
What you got?
Relax. Let it all hang out.
You thought they were just building up. All of a sudden, they're like, "I'm going to rotate that cogwheel so hard right now."
Just relax. No, honestly, I mean, people get tension in their upper shoulders, and we call it the traps levator area. So much, and especially driving or stress at work and stuff like that. The funny thing is that the stress alters our breathing patterns. And the natural reaction is to kind of start stiffening up the tummy, that type of thing. I think if people just kind of let everything hang out, they just kind of really relax. So obviously not letting it hang, like letting your tummy go and just falling in, like letting your spine slump, but just letting it relax. You just open up so much more, you open up the ability for the diaphragm to actually do its job, which is to breathe. And about 12 times out of 10, we get patients to just relax their stomach and the tension goes away in the neck. I did say 12 times out of 10 too. So.
Oh, I sorry.
You didn't even catch it.
You saw me staring into space, like I'm thinking. I don't know if you can tell, but like partially doing like the hosting of the podcast. I'm like, oh, okay, he's finishing an idea right now. I gotta make sure I know where I'm going with this thing.
Yeah. But no, I think if people can actually just kind of learn how to let their tummy go. So if they're feeling tension in their neck or tension in their upper shoulders, and they just relax everything. So if they're driving and they have their seatbelt on, which hopefully you should, just let your stomach relax into the seatbelt that goes across your waist. And you can just breathe quietly in through your nose into that, make that tighter. Or if you're standing up, or if you're sitting down, and you're wearing a belt, try and make your belt tighter whenever you breathe in. Not loud though, just nice and quiet.
Why do people have belts around their stomach anyways? I don't like. What?
They're Italian.
Where in the U.S. are we talking about this right now?
No, I'm not talking about around the belly button, actually. I'm talking about your regular waist. So they obviously wear it lower, but that's your target.
Okay.
So the distance is further away than what we want. And so creating the cue of distance, the further things are away, the better reaction you get.
So just before we close as well, I think that you alluded to breathing as being an important thing. I'm sure you have a whole spiel you tell patients the first few times about breathing and the importance of it and blah, blah, blah. Give it to me.
Breathing affects everything. Carol Levitt, he was a Czech neurologist. The guy was practicing up until he was 97 years old. He had the phrase, if breathing can't be normalized, then no other movement pattern can be. essentially what that means is it doesn't matter how much, Seb, you and I try and correct people's movement. If their breathing patterns are off in any way, things are just going to kind of keep resetting. So it's poor breathing patterns just create so much non-active tension. What I mean by that is like people are not actively tensing up, but our brain perceives this threat that we can't breathe, so it creates this protective tone in the body. Time and time again, we've had people who can't touch their toes, get them breathing a little bit, tone relaxes, and they can touch their toes. So I think moving forward with the breathing, it has to change. And I think the two biggest things that get left behind, get left on the table in our profession, and our profession being movement therapists, not just chiropractors, but
you weren't going to say specialists, were you?
Yeah.
It might be coined somewhere.
Yeah, maybe. We don't know. Our breathing, okay, and the feet. Those two things get left on the table all the time, and they're probably two of the most important things in movement.
Yeah, our discipline seems to focus a lot on the spine, which obviously when you go deeper into the theory of, or the back history of chiropractic, there is merit to why they're doing that, because that's based upon the theory. It's just a little different theory we're working with right now.
Right. Yeah.
So, all right. So we're around 40 minutes here. I can't believe I held eye contact unblinkingly with you for 40 minutes.
I told you I was going to give you 50 minutes of uninterrupted eye contact.
50 minutes?
Yeah.
Oh, you want 10 more?
Well, I'm going to continue, even if we stop now.
Okay. How was your day today?
It was fantastic, actually.
Give me a good story. One good story.
I actually did a workshop for Equinox Huntington today on cueing, on coaching.
Really?
And towards the end of the 2-hour workshop, I had one of the newer trainers come up and try and teach me how to deadlift. And we just got through this whole thing of, internal versus external cueing, and how we don't want to use words like body parts internal, right?
He told you to contract your peroneals?
He did not.
Your
he actually
perineals?
But like he got up and he described the movement, and every single word was like an internal cue. Mm-hmm. But then he goes, "Hey, would you like this? Would you like to use this kettlebell or that kettlebell?" And I stopped. I'm like, "Hang on, are you asking me, or are you asking like the patient me that you're playing with?" He's like, "No, I'm asking you." I was like, "Okay, time out." And I looked at him. I was like, "You have no idea what gold he just said." And it's like he had no idea, like he didn't know. So what he did is he gave me a choice, right? So I have a choice. So he created autonomy, right? And so if we create autonomy meaning like a choice in our patients or our athletes, or in their case their clients, whatever they choose to do, they now know that they chose that, and their attention and their focus is going to be on that task more than if it was just like, "Hey, do this." Mm-hmm. So he didn't even know he did something really good, even though he was coached me poorly. Mm-hmm. So that was actually something pretty cool today. And I'm glad he said that too, because I was going to completely forget about that. I had like 4 minutes left, and I was like, I didn't even touch on that topic.
Oh, that was part of your list of topics.
It was on there too. So it was gold. I was like, thank you. I told him afterwards, I was like, thanks for doing that.
What were you gonna like? What are other things that the trainers could ask? Like, you want to touch my right or left bicep before you start?
Well, we did talk about muscle isolation a little bit.
Yeah.
Yeah.
Is that they must still be doing that? I mean, it's for physique, right?
Well, yeah. I mean, it's okay to get a couple of curls, superset with some tries.
Curls for the girls, tries for the guys.
The big difference between you and I, though, you use the 30s and I use the 80s for curls. So
80 what?
Pounds.
Oh, no, you don't.
Each arms. Yeah.
Let's see. Right now.
Okay. Let's do it. I did 5x3 single arm bent over rows with 205 the other day.
Single arm bent over rows?
Yeah.
I don't believe that.
It's a loadable dumbbell.
I don't believe you went to the gym at all. How much do you weigh again?
I'll show you my check-in.
I think, yeah, I bet you checked in there.
I did.
I'll check your MySpace.
Mm-hmm.
So I think I've been asking almost everybody this recently in the podcast. So how tall are you and how much do you weigh?
I'm 6 foot 255.
255. Yeah, I usually have a really good game. I don't know if I told you, I'm good at guessing. Usually women's weights. Mm-hmm. I don't think if I had to guess 255, but I'm usually within about 3 pounds either way.
Yeah.
But it seems like my estimation above 200 pounds is really bad. So I don't even know.
200 pounds is like kind of skewed, right?
Well, yeah. It's like it's totally not even close. Like I could be like, I could have said you're like 230. You're like, no, dude, I'm 255. Not even close.
Right.
So, yeah.
That's fun.
Well, what else you got? Because you got 6 more minutes.
6 more minutes.
6 more minutes, bro. You don't want me to start
Just-
talking for 6 minutes.
Just misery to everybody who's listening. 6 minutes of pain.
Well, I'll tell you this. Before anyone ever tunes out because they realize, oh shoot, there's 6 minutes left of this, we should probably get Cody's get his contact, how to reach him, in case you want to talk to him or just see him do 80-pound bicep curls in a preacher manner.
No preacher. That's rough. So you guys can follow me or my practice on Instagram at Max Perform Chiro. So MAXPERFORMCHIRO. Our Facebook is Maximum Performance Chiropractic, and you'll see a picture of our logo. It's 2 little circles. It's a sweet logo.
Who made that, anyways?
We actually had somebody make it. We did not make it. We had a graphic designer make it.
Fancy.
Yeah.
Well, cool.
Yeah.
What is your phone number there?
714-979-3672.
Good deal.
Yeah.
Yeah, I don't know if everyone knows. Actually, Cody's probably the closest to local competitor that I have, but I wanted to have him in because I think he has a lot of knowledge that you guys can get, and I personally think there's enough people around that need help that we don't need to think of as competitors at all. So, I mean, how many miles away from you? Like 10 minutes, 15 minutes?
Yeah, maybe.
Yeah, you live like 2 blocks.
Yeah, pretty close.
Yeah. Cool.
Yeah, I wouldn't really consider it. I really wouldn't consider it competition though too, because I think our sole goal for patients is patient-centered care. We want to get people better, right?
Yeah.
And I don't know if they've came, but if I had no space in the schedule, or if I was going to be going, I've sent people to you. I don't know if they came. You wouldn't tell me because it would break HIPAA. But
oh no, I'd probably tell you. HIPAA's not listening.
You didn't hear that.
Yeah. I know. But the great thing is they probably signed that waiver.
Name and birthday were left out.
Yeah. But no, you can have them sign a waiver where like you're allowed to co-manage and so on.
Yeah.
But no, I agree too. Like I would send people to you. Like if I was out of town or if this podcast took off. By the way, everyone subscribe and everything because I like working with people. But man, I like sharing knowledge a lot more. Yeah. I would love if everyone packed Cody's doors and I just ended up podcasting about every single thing that he has to say that I know he left out because he's on guarded first podcasting. This is your first podcast?
Second podcast.
What was your other one?
It was on Marianne and I were on the Dr. Bo show. So Bo Brown, oh my God.
Is that BOI?
BEAU.
Oh, then
Bo Beard. Jesus. Sorry.
Yeah.
He's in, I think he's in Birmingham. He's in Alabama.
Yeah.
They have a practice called Farm. It's actually really legit.
Was it the P or an F?
F-A-R-M.
Oh, good. I would have figured it was the farm.
It's good.
The P.
No, they don't have a green plus sign on the front door. No, Bo's good. You haven't met Bo, have you?
No, I don't think so.
Dude. Yeah, it's good. Him and his wife, Sloan. They're legit.
Is he going to the? I'm going to go to the Perform Better seminar. This
Which one?
The summit.
Long Beach.
The 3-day one.
Yeah, we're thinking about either doing that or we're thinking about going to Chicago.
During that same time, or that's where they have
the
the
Chicago one. Yeah, the Chicago Perform Better.
I'm sure they get a whole
Nick
different.
Winkleman's going to be out there, so
They get a whole different speaker schedule, right?
they do. Yeah.
Yeah, I don't think I've been in I think it's been about 7 years or so. I just figured I wouldn't revisit that seminar for 3-4 years because it'd be the same ideas over and over again.
Yeah, they're starting to. Things are starting to change a little bit. So obviously you're going to have the same kind of similar talks with different topics. Mm-hmm. Winkleman's talk every year is different. Charlie Weingroff's talk every year is different. Levinson's is different every year. Mm-hmm. Chicago looks like a really solid lineup. Mm-hmm. Long Beach looks good too. Mm-hmm. So hopefully we'd be able to, ideally, do both.
Yeah. Well, I like that I like when they share new things. I don't care if they're wrong. Mm-hmm. I just want to hear something different.
Yeah.
Like at all. I feel like everyone falls in suit. Like they follow these big paradigms of the techniques or screening methods for years and years and years, and it gets really boring.
Right.
Okay. Anything else you'd like to share?
No, I think we're good.
Cool. All right, everyone say goodbye to Cody. It has actually been 49 minutes and 30 seconds, so you're almost succeeded there. Cool. So everyone, thanks for tuning in for the podcast today. Again, if you want to submit a question, go to P2, that is the number, sportsasplural.care.com. That is my website. I have tons of free information on there with different types of conditions you might have and so on. And I really, really want to share as much free information as I can so that everyone gets to go in and have a good educated conversation with their healthcare provider and not have to be educated on anatomy and why are we doing this, why we do that. And so I try to hit all that with there. So if you guys want to leave a question for me on there, there is a SpeakPipe button right in the front, and all the podcasts are listed there. You can access them at any time. So again, P2 Sports Care, and thank you for tuning in. Say bye, Cody.
Bye.
See ya.